Hello friends, I am Pradeep here. Now we move on to the next section, that is shock and blood transfusion. I have made this topic in three videos. The first video we will be discussing about pathophysiology, clinical features and severity of shock, followed by the management of shock in second video, and the third video includes hemorrhage and blood transfusion. Let's move on to the first video. So what is shock? Shock is nothing but a systemic state of low tissue perfusion. Low tissue perfusion means less blood supply to the tissue or cell, which is inadequate for normal cellular respiration. So that blood supply will carry less amount of oxygen, which is not enough for the cellular functions to be carried out. So the shock is nothing but it's equivalent to a engine in a car. When there is less petrol and less air, there will be less and there will be no internal combustion happening. So a car with no petrol and air is going to be considered as a shock, as in medical terms, and this shock is considered as a common cause of death in surgical patients. So what happens at the cellular level? So as I already mentioned, there is inadequate perfusion, that means decreased blood supply. So what will happen? The cell will have less amount of oxygen. That terminology is called hypoxia. That is called cellular hypoxia. And what will happen? Cellular hypoxia occurs immediately. It will cause anaerobic metabolism. So what is meant by anaerobic metabolism? Generally, when the cell is receiving more amount of oxygen, there will be aerobic metabolism. Anaerobic means in the absence of oxygen, whatever metabolism that happens is called anaerobic metabolism. Right from biochemistry, if you remember, glucose undergoes anaerobic metabolism. The final end product is going to be lactic acid. Lactic acid, when it accumulates inside the cell, there will be the pH will be reduced since it is an acid in nature. So whenever there is any acid state, systemic acid state, it is called metabolic acidosis. So when will you call a metabolic acidosis? When the pH is less than 7.35. That is called metabolic acidosis, right? So whenever there is a metabolic acidosis, the cell is in a state of a shock, right? So the all pumps, all the cellular activities will get heralded and there will be some misfunction, so leading on to cellular membrane dysfunction. All pump activities will be lost and the intracellular organelles will be triggered to digest the entire cell and finally leading on to cell death. So hypoxia, decreased perfusion, hypoxia, acidosis, and over a period of time it undergoes into cell death. And also this cellular destruction leading on to efflux of potassium. So in the potassium, intracellular potassium will get excreted and there will be local inflammatory changes that will cause that will injure the capillary endothelium of the vessels. All these will cause tissue edema. So this tissue edema will also cause inadequate perfusion. So whenever the cell is surrounded by fully water content, then there will be increased pressure. So increased pressure, when there is increased pressure, there will be again decreased blood flow to the cell, which goes into a vicious cycle, right? So you have to remember, decreased perfusion, cellular hypoxia, increased lactic acid accumulation due to anaerobic metabolism, metabolic acidosis, cellular function disruption, finally leading on to cell death, right? So there are three important physiological criteria. So this is called lethal trial. So whenever there is acidosis, metabolic acidosis, generally acidosis occurs due to decreased perfusion. So the decreased perfusion can be due to any occlusion like vessel occlusion, that is coagulopathy. Due to coagulopathy, there will be vessel occlusion or bleeding. When there is vessel occlusion, decreased oxygen to the cell and tissue, so anaerobic metabolism, increased lactic acid, that forms acidosis. Whenever there is acidosis, there will be efflux of potassium efflux. So what will happen? It will cause decreased heart function. Whenever there is decreased heart function, when your heart is not pumping good, that means your basal metabolic rate is reduced, so there will be hypothermia, that is hypothermia is decreased temperature. Whenever there is decreased temperature, again the blood will not clot very well, so it or the blood will there will be some coagulation abnormality, since the all coagulation factors are dependent on temperature. Whenever there is hypothermia, the coagulation slows down, leading on to coagulopathy. So all these are vicious cycle, it causes a vicious cycle. So these three entities are called lethal triad or deadly triad. So what happens when there is a decreased blood supply to the tissue perfusion? So but the patient has to live, right? So what will happen, they will bypass all the blood supply from the unessential or the non-essential organs to the vital organs. The vital organs are heart, lung, kidneys, brain and liver. So from where they will shift, the blood supply from skin, muscle and gastrointestinal tract to the vital organs, so that these vital organs receive adequate amount of oxygen. So these vital organ cells will derive more amount of oxygen and function well, or else the patient might die. All these things can happen. This is called a called compensation. Okay, so all these can happen and last for almost, the body can adjust itself for almost 12 hours to 24 hours, beyond which it will go into uncompensation or decompensation and finally irreversible, right? So we should not allow the body to enter into, or allow the patient to enter into such state. When the patient enters into irreversible state, it cannot be treated. So what happens at the system level? So I already mentioned, there will be shunt of blood from skin, muscle and GIT to the vital organs to maintain the, or to recover from shock. So what happens generally whenever there is any shock, what happens, there is inadequate organ perfusion. So when skin gets lesser perfusion, and preferentially I mentioned skin, it will prevent the blood supply to the skin, thereby diverting that blood supply to the vital organs. So all the blood vessels will undergo vasoconstriction. Vasoconstriction means it will be constricting the vessels. So the patient will have cold mottled extremities, right? So the brain also, the blood flow will be reduced. So over a period of time, the brain function will get deteriorated and there will be progressive decrease in the consciousness, that is loss of consciousness. So heart will also decrease the blood supply, so decrease myocardial contractility. So finally it forms pulseless electrical activity, and there will be a compensatory decrease in blood pressure. The decreased blood pressure will cause, because hypovolemic shock is nothing but decreased volume, okay, decreased volume in the whole body. So that will cause increase in heart rate to form tachycardia. Kidneys will have low blood flow and finally there will be oliguria. Oliguria means decreased urine output, and in all other body tissue there will be increased accumulation of lactic acid, thereby forming a state of metabolic acidosis. Whenever there is a state of metabolic acidosis, our body will try to compensate for that acidosis by excreting more amount of carbon dioxide, right? So there will be compensatory respiratory alkalosis. For metabolic acidosis, there will be compensatory respiratory alkalosis. What is that respiratory alkalosis? Patient will have hyperventilation. When you hyperventilate, that means you are ventilating, that means you are breathing, you are increasing your minute volume, right? Like when you are increasing the minute volume, more amount of carbon dioxide will be excreted, thereby entering into phase of respiratory alkalosis. This also can happen for almost 6 to 12 hours, beyond which it will go into irreversible state. So at systemic level, the clinical features will be vasoconstriction, peripheral vasoconstriction leading on to cold mortal extremities, decreased mentation, and tachycardia will be there, and oliguria will be there, and respiratory alkalosis and generalized metabolic acidosis will be there, right? So after prolonged ischemia, all these things can happen and last for almost 6 hours, beyond which Even if you reperfuse, that means if you restore the blood flow, it will lead on to a state called reperfusion injury. What is this reperfusion injury? Over a period of ischemia, all these toxic metabolites and the acid and the potassium will be out of the cell. So when you reperfuse, all these toxic metabolites, acid and potassium, they will enter into the circulation. So through the circulation, they will be taken out to all vital organs and go and injure the vital organs, like that, right? So the acid and potassium load will cause myocardial depression, and there will be vasodilatation and hypotension, and the other thing will form vascular thrombi, thereby causing multiple organ failures and finally death. So this is reperfusion injury. So you should remember this. So what all patients should require management, and what all patients will be beyond the management, we have to know those. Then moving on to the types of shock. The shock can be broadly classified into cardiogenic shock, hemorrhagic shock and distributive shock. Cardiogenic shock means there is some problem with the heart function. When it is going to be primary heart failure, or heart is going in for heart attack, that is myocardial infarction, that is called cardiogenic shock. Or something that is not allowing the heart to function properly, like there is a tamponade. Tamponade means that is cardiac tamponade means there is collection of some blood or fluid in the pericardial. This is heart is called the pericardium, and there is collection of fluid. What will happen? It will compress the heart and prevents the heart from pumping. So that is called obstructive shock. So extrinsic type of heart cardiogenic shock is called obstructive shock. The other variety is going to be hemorrhagic or hypovolemic shock. Hypovolemic shock is nothing but decreased blood volume, or decreased intravascular volume. And finally distributive shock, wherein there will capillary regions, there will be vasodilatation. So there will be decreased entry to the heart as well as decreased entry to the organs. So entire blood pool will be pooled in the organs, it will not reach the heart. So that is called distributive shock. So to start with hypovolemic shock. Hypovolemic shock is reduced intravascular volume leading on to decreased cardiac output. Okay. So the common causes, one is going to be hemorrhage and trauma. The other one is burns, gastrointestinal loss, renal loss and third space loss. So these are classical hypovolemic shock due to decreased intravascular volume. And what is the most important component of intravascular area? One is blood. So when there is hemorrhage, it is called hemorrhagic shock. So what happens in a hypovolemic shock? So when there is decreased intravascular volume, there will be decreased preload to the heart. So that means decreased amount of volume is available for the heart to pump. So what will happen? The heart rate, in a response to it, the heart rate will rise and the JVP will be reduced because of decreased preload. You should know what the, just recollect the physiology, cardiac physiology, right? And the peripheries will be cold because of vasoconstriction, thereby allowing the blood supply to the vital organs. In cardiogenic shock, what happens? There is intrinsic cardiac failure. It can be due to myocardial infarction, arrhythmias, valve disorder, or even heart failure. So here the heart cannot pump properly, so leading on to increased heart rate, and peripheries will be cold, just like hypovolemic shock. But since the heart is not able to pump properly, whatever the blood that is coming into the heart is not efficiently pumped out. So whatever that is inflow, the inflow to the heart will always be raised. That's why JVP is raised. So here the preload will be increased as the heart is not able to pump it out properly. Obstructive shock is something that is obstructing or preventing the heart from pumping out effectively. Here also there will be JVP will be raised. It is not allowing the, something is not allowing the blood flow to enter into the heart. The common condition is pulmonary embolism, which occurs in the right pulmonary artery. So when there is pulmonary embolism, so there will be decreased oxygen exchange, and finally there will be obstructive shock. Tension pneumothorax, there will be mediastinal shift. tension pneumothorax is nothing but there is collection of air in the pleural cavity. The air progressively collects, thereby compresses the entire lung and shifts the mediastinum to the other side. In such cases, while shifting the mediastinum to the other side, the superior vena cava will be obstructed. So there will be reduced blood flow to the heart, right? And pericardial tamponade, as I described in the previous slide. Constrictive pericarditis, restrictive cardiomyopathy all have a similar feature by increasing the preload and avoiding the blood supply to enter into the heart, right? So thereby leading on to heart failure or a state called obstructive shock. And the third one is distributive shock. Distributive shock is nothing but that the shock that occurs due to severe peripheral vasodilation, as described in the previous slide, wherein we described about the distributive shock. So in the distributive shock, the peripheries will be totally vasodilated. So the common types of distributive shock, one is septic shock, another one is anaphylactic shock. Anaphylactic shock is nothing but something that occurs as a result of anaphylaxis. And neurogenic shock, that is spinal cord injury, neurogenic shock. So whenever the spinal cord injury, there will be severe hypotension. All blood will be pooled in the extremities. So the patient will end up in a state called systemic shock, that is called neurogenic shock. In septic shock, what happens when there are increased gram-negative bacteria that will cause, that will liberate endotoxins. Endotoxins are nothing but the infective end product of bacteria. They will cause a state called systemic endotoxinemia. They will form, they will interact with the cells, thereby forming hypotension and peripheral vasodilatation. That is called septic shock. An anaphylactic shock is usually due to increased histamine release. Histamine release from the mast cells. So the most important feature is, as for all shock will have tachycardia, and the JVP will be reduced and the peripheries will be warm. So since there is peripheral vasodilatation as against peripheral vasoconstriction in hypovolemic cardiogenic shock, here the peripheries will be warm. The hypovolemic shock can be either hemorrhagic or non-hemorrhagic. Hemorrhagic as a result of any bleeding due to trauma, surgery or any organs. Non-hemorrhagic, there will be decreased intravascular volume resulting from vomiting, diarrhea. Burns will cause excessive fluid loss or third space fluid loss, and usage of diuretics. Nephrotic syndrome. Pancreatitis will cause severe ascites, and there was severe inflammatory reaction, thereby forming increased peritoneal fluid collection, that is also called third space fluid. All these forms hypovolemic shock. And moving on to the hemodynamic profile of various shock. So as we described earlier, in hypovolemia there will be decreased preload, so the venous pressure is low. Since the venous pressure is low, the cardiac output will be obviously low. To compensate for it, there will be increased vascular resistance. The similar thing happens for cardiogenic shock, but the only thing is the preload will be higher. So that is, venous pressure will be higher as the heart is not able to pump it out properly. In obstructive shock, where something is obstructing the heart from pumping, that also causes increased venous pressure. These two will have similar hemodynamic profile. And distributive shock, there will be peripheral vasodilatation. When there is peripheral vasodilatation, obviously the preload will be low, decreased preload. Okay, and the cardiac output will be high to compensate for the decreased peripheral vascular resistance. So generally, when BP is low, heart rate will be high, or when the BP is high, the heart rate will be low. That will be the normal physiological response. So in distributive shock, there will be peripheral vasodilatation. So when there is peripheral vasodilatation, there will be decreased blood flow to the heart, that means decreased preload. To compensate for it, the heart is pumping it high, so hence the cardiac output will be high. The two important criteria, mixed venous saturation and base deficit. Base deficit is nothing but clinical measure of metabolic acidosis. It is nothing but the amount of base that is required to titrate a liter of blood to a pH of 7.40, that is the normal pH level. So whenever the base deficit is, whenever the lactic acid is high, the base deficit will also be high. Lactic acid occurs as a result of anaerobic respiration, that is due to cellular hypoxia. So lactic acidosis causes metabolic acidosis. When the base deficit is high, patient is in severe metabolic acidosis. So in all shock, base deficit will be high, right? And the next important thing is, and this base deficit can be calculated from ABG or arterial blood gas analysis, whereby you sample the patient from the radial artery or a femoral artery. Any arterial sample will be taken and will be subjected to analysis. The next thing is venous oxygen saturation. Venous oxygen saturation reflects the events that are happening at the cellular level, whether the cell is consuming more amount of oxygen or the cell is not consuming more amount of oxygen. Generally, arterial saturation oxygen saturation will be near to 100%. The venous saturation normally it will be around 50 to 70%. When the venous saturation is less than 50%, it reflects that more amount of oxygen is consumed at the cellular level because of the shock state that occurs in hypovolemic and cardiogenic shock. When the venous saturation is more than 70%, oxygen is underutilized. So this classically occurs in distributive shock. So if you see, the mixed venous saturation is high only in distributive shock. This is an important MCQ. The clinical features, as we described earlier, patient will have tachycardia, hypotension. Because of hypotension, cool, moist or motile extremities, rapid breathing. To have a compensation to compensate the metabolic acidosis, patient will be hyperventilating, thereby to excrete more amount of carbon dioxide. Patient will have nausea, vomiting, hypotension, weak pulse, and altered consciousness because of the decreased blood supply to the brain, and patient will be initially it will be irritable and restless. Patient may have sweating, anxious. These are various other clinical features of shock. Moving on to the stages of shock. As we described earlier, initially the shock will be compensated for a period of time, beyond which it will enter into decompensated phase and finally into the irreversible phase. During compensated phase, it will decrease the blood flow to the non-essential organs, thereby maintaining the blood flow to the kidneys, lungs and brain. During this period, patient will be alert, patient will have normal breathing, patient will have normal urine output. Only signs will be tachycardia and not even hypotension. Only tachycardia will be the only feature in a compensated shock. Whereas when the patient goes into decompensated, that means even after when the loss exceeds the compensated mechanism, even the blood flow to the renal, kidneys, lungs, brain will deteriorate, and finally patient will undergo into a decompensated phase. The clinical features, when the patient is in compensated phase, because of the metabolic acidosis, is the main picture that is happening at the cellular level, and patient will have tachycardia. Okay, rest all things will be normal. Patient moves into phase of decompensation. It can be further categorized into mild, moderate and severe. In the mild phase, there will from the moderate phase, urine output will be reduced and patient will get drowsiness, whereas pulse rate and respiratory rate will be increased in all phases of shock, and BP will start to reduce from the moderate phase. So remember, patient will have increased tachycardia is the earliest sign of shock. Tachycardia is the earliest sign of shock. Hypotension usually occurs very late phase of shock. So patient blood pressure is normal, so patient is not in shock. That is the wrong thing. So hypertension usually occurs at the later stages of shock. So you need to remember that. So urine output and consciousness level and blood pressure starts to deteriorate from the moderate phase of shock. Whereas in severe shock, patient will be anuric, comatose, patient will have a labored breathing, and patient will have severe hypotension. This graph shows as the volume decreases, patient goes in for decompensation. Once after decompensation, patient goes into irreversible state wherein the patient pulse, BP, everything will come down to deadline, right? So finally, irreversible shock, final cell death has happened. There is no time for the body to recover. The compensatory mechanism have failed. The vital organ blood supply has been lost, and patient has went into more multiple organ failure. And whatever treatment we give, patient is not responding. That is a state of irreversible shock, and finally death ensues. Right. So with this we have completed the definition of shock, the causes of shock, what are the pathophysiology of shock, stages, etc. Right. We will discuss this with few MCQs. So lethal triad is all except. So you remember the diagram. Acidosis causes potassium efflux, decreased cardiac function, decreased basal metabolic rate, so hypothermia. Hypothermia, coagulation abnormality will be there, so patient will develop coagulopathy. Coagulopathy, again decreased blood flow, so decreased blood flow will cause decreased oxygen, so more amount of cellular anaerobic metabolism leading on to acidosis. So hypoxia is not a feature of lethal triad. Which of the following is not a feature of distributive shock? Distributive shock means peripheral vasodilatation. So there will be decreased peripheral vascular resistance. So patient will have hypotension as in all shock. Patient will have tachycardia as in all shock. Distributive shock, septic shock, anaphylactic shock and neurogenic shock are three types of distributive shock. Whereas increased peripheral vascular resistance is not a feature of distributive shock because peripheral vascular resistance will be very low. Right, so decreased, so thereby leading on to vasodilation. Which of the following is not seen in moderately decompensated shock? So it's based on the tabular column. Patient will have moderate. What are the events that will happen? The urine output will start to reduce, patient will become drowsy and patient BP will tend to fall. Labored respiration is seen in severe shock, okay, not in moderate shock. Compensation of shock occurs by shifting the blood supply to the vital organs from all except. Generally, the blood supply to skin, muscle and GIT will be cut off and they will be diverted to vital organs like heart, lungs, brain and kidneys. So brain is not the answer. So thank you. So we will discuss about the management of shock and hemorrhage and blood transfusion in the next video. Thank you.